infectious disease. It plays a vital role in our society by preventing epidemics, protecting against environmental hazards, reducing injuries, encouraging healthy behaviors, and ensuring access to quality healthcare services, and responding to disasters. Public health is not just one organization, it is a system of partners working together, including state and local health departments, tribal health organizations, healthcare providers, emergency responders, schools, community coalitions, all working together. Together, these entities strive toward the vision of every South Dakotan healthy and strong, and we do this by collectively promoting, protecting, and improving the health across the state. So next slide. We are proud to introduce our speakers today, who I am sure many of you are aware of and are familiar with. We have Dr. James Michael Keegan, an infectious disease specialist with more than 25 years of experience in the medical field, and he serves as the firm's antibiotic stewardship program service line leader. Throughout his career of practicing medicine, Dr. Keegan has taken an active role in improving the quality of healthcare and patient outcomes by serving in numerous medical director and hospital executive leadership positions. Dr. Keegan has taken a special interest in solving the negative impact of over-reliance on broad-spectrum antibiotics and has designed and implemented numerous and successful antibiotic stewardship programs that have shown to decrease the incidence of drug-resistant bacteria. Next, we have Randy Mason. Randy is an inspiring and innovative healthcare leader dedicated to driving change by creating value across the healthcare industry. She specializes in antibiotic stewardship, infection prevention, and patient safety across the continuum of care. She has been instrumental in the development of high standards of practice, evaluating patient care for effectiveness, and implementing cutting-edge changes to organizations in the most cost-efficient manner possible using lean methodologies. Randy received her Bachelor of Science in Nursing from South Dakota State University, and she has extensive experience in the healthcare industry. So I will turn it over to both of you to get us started. And like Leah said, put any questions you have in chat. And Dr. Keegan and Randy, take it away.
Well, thank you. This is Randy Mason. Sorry, my video is not working today. I'm not sure why that is, but wanted to thank you all for joining us. I see a lot of familiar names here. We have had the privilege of working with you all over the last few years within, the critical access hospitals, long-term care, and other settings. We currently work with about 40 hospitals across the United States. Dr. Keegan and I have done anything from clinical to administrative to quality work and now consulting. And we work with many of you. And so we get a lot of questions regarding upper respiratory illnesses and how to prevent, how to manage, how to treat. And so we're happy to go over that with you today. We're excited. And like I said, thanks for joining us. And with that, I'm actually going to hand it over to Dr. Keegan to take over.
Thank you, Randy. What we'll review today is the epidemiology of upper respiratory infections, but more respiratory infections in general. And I'll explain that as we move along, which essentially is viral epidemiology. And then we'll get into the specifics there of how things have evolved over time. We'll talk about some diagnostic considerations, and then we'll talk about some treatment considerations that this day and age we have to, in the era of microbiome protection science, we have to, in making an antibiotic decision, not only consider the individual patient, but our community of patients, essentially a population health type of decision. And at the end, we'll have 3 case studies of patients that we've seen over the last couple years that I think exemplify some of the points that we intend to make. Now, before moving on, I'd like to share with you a historical perspective of what has happened in Rapid City. What we noticed about 25 years ago was with the introduction of newer antibiotics, and by newer, the strategy at the time from the pharmaceutical industry was let's develop antibiotics that kill any potential pathogen in a particular scenario or presentation, clinical presentation, not understanding at the time what the damage to our protective microbiome that would lead to. So in Rapid City, we had a unique situation where we have one microbiology lab serving a larger region. And as we saw the introduction of newer antibiotics, we saw dramatic increase in resistant bacterial infections. Our MRSA rate went from 28% of total staph infections to about 50%. Our gram-negative bacteria became more resistant, with Pseudomonas in particular dropping from 95% sensitive to about 75% sensitive to the most common antibiotics available at the time, orally, that is. And we started seeing vancomycin-resistant enterococcus, increasing amounts of Clostridium difficile. And so the literature at the time suggested that some of these new antibiotics actually were starting to show a 5 times increased risk of MRSA if you're exposed to them. And so what we elected to do was go back to the older antibiotics, the penicillins, the first generation cephalosporins, and so forth, aminoglycosides, and put the newer antibiotics on reserve status for specifically when we had to use them. And what we found in doing so was that the MRSA rate dropped back down to about 30-35%. The gram-negative sensitivity improved, including Pseudomonas, back up to 90%. We pretty much didn't see vancomycin-resistant enterococcus for many years thereafter, and our C. difficile rates improved. We reported this in the South Dakota Medical Journal in 2001, and at the time we didn't fully understand why we saw such an improvement. But as it turns out, reviewing the literature over the last 25 years, that's the first reported case that I can find in the medical literature which showed that you could actually reverse the rise of resistant bacteria. So because of that, our goal became, can we maintain our antibiotics just as effective 10 years later and 20 years later, and now going on 30 years later as we progress over time? And sure enough, we've been able to do that. So essentially what antibiotic stewardship is, which is what we have a particular interest in, is antibiotic preservation and bacterial stewardship, or essentially microbiome stewardship. And we'll get into that further as we go along. So having said that, we have to look at antibiotics differently, because the strategy historically has been, well, just in case, let's use antibiotics to be careful or be safe. But that empiric coverage with antibiotics, now we know, has potential harm associated. And the newer antibiotics in particular that kill our gram-positive bacteria, gram-negative bacteria, and anaerobic bacteria in our system that are actually part of our protective microbiome can be very damaging, and we'll get into the specifics of that as well. So we'll focus on upper respiratory infections and where the opportunities are there. This slide, I'm not a pediatric infectious disease, so I'm leaning on Cleveland Clinic a little bit here. But as it turns out, the bronchiolitis, which is a viral infection of the lower, most distant airways, affects generally young babies, young neonatal age, young children, and can be quite severe, but it doesn't mean that it's a bacterial cause. So any virus, you continue to look for secondary bacterial infections, but in particular, the viruses that are most commonly reported with bronchiolitis are respiratory syncytial virus, influenza, adenovirus, parainfluenza, and there's 3 or 4 different main strains that we detect for parainfluenza. Human metapneumovirus, which is the virus now felt to be circulating in China pretty extensively, and then more recently, COVID. Next slide, please. So I wanted to review with you the epidemiology of viral infections, because with bronchiolitis, just the same in adults with bronchitis and adults with sinusitis, 98% of the pathogens in those 3 situations are viral. So only 2% of sinusitis is bacterial. And of that 2%, 20 to 40% is pneumococcus, about 20% is Haemophilus, and up to 10% is Moraxella. Now, in unusual circumstances, it can be staph, around 5% or so, but that's generally after multiple courses of antibiotics, or people that are maybe compromised, or after surgery, for instance. So having said that, what we really want to do is focus on the epidemiology of the viral pathogens. This is a de-identified weekly viral report based on incidents and common viruses detected through PCR detection. And this type of graph, if you have access to it, is very helpful when you see patients, because often a patient presenting with upper respiratory infection, if you can put a name to the likely virus, or you can confirm the name of the virus that they have, they're a lot more accepting of not receiving antibiotics. If a person has a viral pneumonia and they're given antibiotics, they have a worse outcome than if they're not given antibiotics. So we're potentially causing harm, as opposed to the philosophy in the past over the years of, well, they're really sick, I'm worried about them, I'll give them an antibiotic. That just doesn't hold now with what we know about microbiome science. We're in an age where we have much better viral molecular diagnostics, as we saw with the COVID pandemic, with rapid antigen testing and then PCR testing. And so in this particular example, with COVID up and influenza A starting to go up, typically in South Dakota, we see this around the end of December, early January or so, with influenza not up yet, RSV starting to tick up a little bit. Rhinovirus and enterovirus continue to be steady over the fall and early winter. Interestingly, back in the 90s, Dr. Mary Jo Jakwa, who's a pathologist microbiologist at the time at the School of Medicine, South Dakota School of Medicine, set up a viral lab in Rapid City, and we were able to monitor the viral epidemiology over time. And what we saw very consistently using direct fluorescent antigen technology and viral culturing was in the early mid-fall, we would see the parainfluenza viruses circulating with RSV and RSV steadily across the fall and winter. And then early in the winter, into the early part of the next year, we would see influenza A and start to see RSV increase, and then human metapneumovirus increase, and then influenza B would come through. And then in the late spring, early summer, we would see enterovirus. And then again, in the late summer, early fall, we would see enterovirus. Now, the medical literature research since then has indicated that enterovirus in particular has several strains that are very temperature sensitive, and as are some strains of rhinovirus that make certain times of the year more favorable to have those types of infection. Next slide, please. These are the viruses that are more commonly detected, though the PCR types of technology currently available with multiple platforms, you can pick up to 20, 25, 30 different pathogens potentially. So here, for instance, the coronavirus, even though it's milder at this particular time, is still the most commonly detected virus in the late fall going into early winter, with influenza A starting to tick up, and right now quite high. In fact, each weekly report from the health department is about a quarter of the total cases that we've seen all through the year so far. The interesting part about rhinovirus and enterovirus is they share genetic patterns so that you're unable to detect them through PCR or distinguish one from the other. And enterovirus, now we're seeing there's certain strains that are fairly common to cause respiratory infections that we probably didn't appreciate a number of years ago. The coronaviruses, other than COVID, are circulating and cause upper respiratory infections similar to rhinovirus, more of a cold type of thing. Nationally, pertussis and mycoplasma are quite elevated compared to what we usually see. So that's important to keep in mind from an epidemiologic standpoint when you see patients. And we'll have some case studies at the end to show you why that's important. Adenovirus occurs sort of sporadically all during the year. And then, as I mentioned, the parainfluenza viruses usually in the early to mid-fall. Influenza B, usually what we see in South Dakota is it can hit often in March or April time frame, so a little longer. So when you're timing your influenza vaccines, we generally shoot for around the Halloween time period, unless there's atypical early cases, then we might try to vaccinate earlier and revaccinate potentially. Next slide, please. So once again, this is a week after that last report. So now you see that the COVID's starting to come down. Influenza is still going up, but maybe leveling off. But I think that the subsequent epidemiologic report since then shows it's a very significant increase further. So it's still very rampant, as we see confirmed from the health department report as well. Next slide, please. Okay, about 10 years ago, Randy and I coined the phrase aggressive diagnostics, conservative therapeutics, which is sort of turning the previous strategy on its head, where you're trying to save money on the diagnostics and you're just using antibiotics to cover all the potential pathogens. Well, the problem with that is we have much better viral molecular diagnostics that show how commonly these viral causes are. In fact, an example is a viral pneumonia or a community-acquired pneumonia presenting to the hospital that turns out to be viral is just as severe in the morbidity and mortality as is a bacterial pneumonia. Now, on chest X-ray, I'd like to bring to your attention the chest X-ray on the right that shows infiltrate with some fluid and above it's labeled pneumonia, to keep in mind, because one of our cases that we're going to present has essentially this chest X-ray. Now, another one that we're presenting is actually going to be a normal looking chest X-ray. But having said that, it still leads to the fact that most all these presentations from a pathogen standpoint are going to be viral, 98% of the time for upper respiratory infections. And now what we're seeing for community-acquired pneumonia is that at least 30%, maybe 50%, and possibly 80% of community-acquired pneumonia is viral. And so with how effective the pneumococcal vaccine is, that's decreased pneumococcus as a cause of community-acquired pneumonia from 17% down to 15%. And so we're seeing viruses being a much more common cause of pneumonia, with COVID being a very good example of how severe a viral pneumonia can be. So what we now know with antibiotic administration, especially broader spectrum antibiotics, is there's just a study that recently came out in children who present with pneumonia that they do not benefit at all from antibiotics and yet have antibiotic-associated complications, whereas they don't otherwise. Now, we're not advocating that, but it does raise the interesting potential that the viral pneumonias are probably a lot more common in children than we had previously thought if antibiotics aren't providing particular benefit. And this is just for outpatient pneumonia in children from this study. Next slide, please. So now therapeutic considerations, there was a very nice painting in one of the medical journals that talked about in Ireland, in Western England, in the 17th or in the 18th and early 19th century, the treatment for children with whooping cough was to pass them underneath a donkey and then over the top of the donkey 3 times. And some donkeys work better than others, and so those donkey owners seem to make more money and were in greater demand. And the reason I bring this up is the concept of primum non nocere. At least first, do no harm when we're seeing our patients and evaluating our patients and residents. And so with antibiotics now, we have to factor in the harm to the microbiome when we are providing antibiotics and making a risk-benefit analysis as is there going to be proven benefit. And so the concept of colonization resistance, our normal bacteria in our intestinal tract and on our skin actually decrease us from being colonized with, say, MRSA on our skin or resistant gram-negatives in our intestinal tract. And so when we use antibiotics, we decrease our protection, our colonization, our protection from being colonized with those types of bacteria. And even C. difficile, if our anaerobic bacteria are intact in our intestine, then if we're exposed to C. difficile spores, which are very common in the environment and the soil and so forth, and as long as our anaerobes are intact, our anaerobes will help protect those spores from breaking down and causing infection. And so very important to understand how our normal bacteria, our microbiome, interact with our immune system to respond appropriately to different antigens that were presented from being exposed to. So the therapeutic considerations in testing for somebody with an upper respiratory infection during the winter months, it's really nice to have the quadruplex PCR available that can test for influenza A and B, COVID, and RSV, because there's obviously treatment for influenza with oseltamivir or Tamiflu, treatment with COVID with Paxlovid, for instance, and remdesivir in certain cases. And then RSV, there's vaccine available, and then monoclonal antibody for protections of neonates. And so there's different prevention strategies in place based on what we are confirming and what we're seeing from a epidemiologic standpoint. Now, we're fortunate to have a call scheduled with Josh Clayton, our South Dakota Department of Health state epidemiologist, this week to discuss the feasibility of putting together a viral epidemiology report on a weekly basis and make it readily available on the listserv to long-term care to critical access hospitals, rural clinics, whoever would benefit potentially from this information. Because once again, if you can share with your patient what we're seeing, what's increased in the community, then a lot more accepting of antibiotic avoidance and antibiotic preservation for future generations and their family and for that community. So we actually, in seeing patients, we just don't tend to see people insistent on antibiotics like we had in the past. And because more often than not, they're relieved that they don't need to be on an antibiotic, and with considerations about their protective bacteria and their having a healthy immune system. Next slide, please. Thank you. So from an antibiotic stewardship standpoint, as I mentioned, it's actually microbiome stewardship and antibiotic preservation. Infections occur, two things have to happen. The person that's infected has to be susceptible to that infection, and they have to be exposed. So infection prevention is essential in trying to decrease exposure. And we'll talk more specifically about some strategies there in place. Antibiotic stewardship and vaccinations help decrease susceptibility. And by that, what I mean is obviously vaccinations, there are some that are extremely effective with the Haemophilus vaccine, for instance, and hepatitis A vaccine, very effective, long track record, excellent response rate when you receive those. There's other vaccines that are less effective, but still very important because how extensively the pathogen is present in the community. And then the more recent pneumococcal vaccines are also extremely effective and definitely worth considering in the at-risk groups. So so vaccinations will decrease susceptibility potentially. I like to think of the West Nile virus if we had a vaccine for that, because essentially what West Nile is after a mosquito bite, injecting the virus, it's a race between your immune system neutralizing that virus and the virus getting to our neuro tissue. And so if any type of vaccine that would enhance the immune response and make it more favorable, that we would win that race potentially would be beneficial. So one way to sort of envision how that would work. Now, antibiotic stewardship, by keeping our normal bacteria in place, we have that resistance, that colonization resistance aspect, but we also probably have a healthier, more appropriate immunologic response as well. We're learning more and more that our normal bacteria are tied into our immune response, correctly recognizing antigen and either upregulating inflammation or downregulating inflammation in response to proper response. So now there's research into antibiotics damaging our immune system, our microbiome, being associated with a number of chronic autoimmune diseases. We know that in children exposed to antibiotics, potentially there's a higher risk of asthma and allergies. And so I think that as that science continues to evolve, I think we'll have a greater appreciation of the specifics of what to be aware of there. Next slide, please. I put this out because there's a lot of confusion on the internet as far as the effectiveness of masks and so forth. University of North Carolina at Chapel Hill engineering department has shown very nicely that masks are beneficial, and subsequent studies about healthcare workers wearing masks during COVID have shown tremendous benefit. Now, surgical masks provide benefit. N95 is better than surgical masks. And when you add eye protection, either goggles or face shields, that's additional protection. So those are additive. Being vaccinated toward common things that we see, influenza in particular, when we work, as Randy mentioned, with our long-term care facility leadership in the state, we go through the pros and cons of the various vaccines, where they're beneficial, how they're beneficial, and what strategies that make sense to employ. From a hand washing standpoint, when I see patients, I wear surgical mask and goggles. I put on gloves, I put alcohol gel on the gloves, and then I shake hands with the patient so that they now have alcohol on their hands, and they generally rub it together and just use that as an opportunity to talk about the value of alcohol gel. Now, two things to keep in mind is alcohol gel does not protect you from C. difficile spores, and it doesn't protect you from norovirus. So when I leave that room and take off my gloves and I wash my hands, generally trying to find a sink where people can see me washing my hands to try to set an example for others as to the value of the hand washing. And alternatively, I think it's a good idea to potentially wash your hands in the exam room so that the patient sees the example of the hand washing. So the problem with prevention is if you're successful, nobody knows that you actually prevented something. And so there's not a lot of thank yous, but I think being diligent in the things that we know are beneficial, and then just setting good examples as leaders in healthcare, I think makes a big difference. Next slide. And we'll end with some case studies because we wanted to leave time for any questions and discussion. But each of these case studies is exemplary of some of the points we're making through the presentation. The first is a 51-year-old female who's on biologic immunosuppressants for psoriasis. She had moved from the eastern side of the state to the western side of the state. And the reasons that's important is now she has a suppressed immune system, and so recognizing what her potential exposures might be that are different now in her new environment, I think is very important, because she developed a cough and fever, weakness that just didn't respond to initial antibiotic attempts, and eventually presented to the hospital, found on chest x-ray and CAT scan to have a nodular infiltrate, subsequently biopsied and found to have tularemia, or Francisella tularensis. And this was a year we saw about 6 to 8 cases of pulmonary tularemia, which is something we need to consider in Western South Dakota, but isn't something that you would commonly have to consider in the eastern part of the state. So we actually reported this case in the South Dakota Medical Journal as exemplary of, as your potential exposures change, especially for immunosuppressant people, it's important to continue to be aware of what the new risks are, recognize that, and she responded very nicely to appropriate antibiotic treatment for the tularemia. The second case, very interesting gentleman, a 74-year-old rancher who presented with a skin lesion, a cough, and fever. The skin lesion was seen in the emergency room and looked consistent with a MRSA type of skin infection. Patient was given Bactrim, which the skin infection improved, and then but after 5 to 7 days or so, it came back and the cough persisted. Now, if you remember the chest x-ray, the large infiltrate, lobar infiltrate that I showed earlier, that's what his x-ray looked like, even though he had a relative non-productive cough. And so he came to a biopsy as well, and his culture showed a bacteria called nocardia, but the type of nocardia is called Beijingensis, which is very unusual. And so why would he have this? 74, he was pretty healthy otherwise. There is our immune system does, at least our adaptive, our part of our immune system, our innate immune system decreases or lessens as we age. Our adaptive immune system actually stays the same or improves, interestingly. So that didn't make sense as far as an immunologic susceptibility. So it was an exposure. What was his exposure? Well, on his ranch, he found some metal pipe that he dug up and was cutting through it. And he said there was a very strong smell to it. And sure enough, we think it essentially was aerosolizing it with tools of cutting the pipe. And so we think he was exposed at that point. Now, nocardia not only affects the skin and the lungs, but it can go to bone and brain as well. And he had lymphadenopathy, he had bone pain, and on CAT scan of his brain, he had a Pons lesion in the Pons area of the midbrain. And he was treated, initially the treatment is Bactrim, but kidneys didn't tolerate that. Moved to a second line antibiotic and treated for 9 months with resolution of his skin lesion, resolution of the brain lesion, and a marked improvement of the infiltrate. So he's continued under observation and care, now off antibiotics and doing very well. And then the last case, I think, is an example, and that's an example, the 74-year-old man, an example of explaining unusual things. We could only find one other report in the literature. It was from Mayo Clinic in Jacksonville of this particular strain of nocardia that responded nicely to the antibiotics that they had used, and we were able to use similar treatment. And then the last case is a 36-year-old male presenting with cough, fever, and shoulder pain. Okay, as we talked earlier, it's important to be aware of what's circulating nationally, and with an increase in mycoplasma and pertussis, we've seen increases in both those in the state as well. And so his illness, interesting aspect of his illness is the shoulder pain. Why, explaining unusual aspects of diseases, I think helps guide you as far as potential pathogens. So mycoplasma is reported to cause arthralgias, in particular, on occasion, single joint arthralgias. But why would a 36-year-old develop this and more extensively than you would expect? So on chest x-ray, he had some worrisome changes. A CAT scan showed that he had air trapping and some early emphysema changes in a non-smoker. So this leads to, when you see unusual things, to continue the workup. And so he would be, the next type of the workup would be assessing him for alpha-1 antitrypsin deficiency. And now that there's some treatment for that, that's very important to catch early and try to mitigate. So an example of, even though we talked about how common viral pathogens are, when there's unusual circumstances of immune suppression or unusual exposures, then we need to really pin that down aggressively, the aggressive diagnostic sign, so that we can be specific with our effective treatment. So with that, I think we'll end and see if there's questions or discussion.
Does anybody have any questions for Dr. Keegan or Randy? I don't see anything in the question and answer or the chat yet, but I have a question, and maybe you addressed it. I had to step away just for a couple minutes. What's your thoughts on nasal colonization? And then also I had a question on probiotics. Do they really help our microbiome?
Yeah, and both excellent questions. I'll do the probiotic one first because that's the most common question that Randy and I get because there's so much literature out there and so much promotion. The bottom line is that the ultimate answer to having a healthy microbiome, in my view, will be a better understanding of optimal probiotics or prebiotics. Right now, essentially what we mainly have is lactobacillus, which is good for vaginal health, but may or may not provide a lot of benefit for intestinal health. And the literature is conflicting on whether there's benefit. My approach over the years is if a patient is on them already and feels like they're beneficial, I don't stop them, but I don't think there's literature to support starting them either. And but I qualify that by saying as we develop better knowledge of our anaerobes and our intestinal bacteria, and I think over time, I think we'll have better options that hopefully will be more protective. Now, the decolonization, I think you're referring to methicillin-resistant staph or Staph aureus colonization. Yeah, there are effective regimens for decolonization, and that's not an uncommon consult that we'll see in the office. If someone has had recurrent infections, we will offer decolonization and then investigate as best we can any types of ongoing exposures and try to minimize those, talk about skin health. And one of the best things is to avoid certain antibiotics that actually dramatically increase your risk of colonization and infection with MRSA. So we'll go through all that, but there are regimens, and in particular, if somebody's going for, say, a prosthetic joint and replacement or prosthetic heart, say a pacemaker or a heart valve surgery, I do think it's a good idea to do a PCR to see if they're colonized, and then do decolonization in advance of that surgery to decrease their subsequent postoperative risk.
Thank you for that, Dr. Keegan. Oops,
Yeah.
sorry, Leah.
No, that's okay. We've got a couple questions that I want to get to in the Q&A. So Miss Jessica Wingen says, do you have any literature to support the only 2% sinusitis is bacterial? I'd love to learn more on that study and share it with a resident who wants antibiotics frequently for a sinus infection. And I think that's a great question. I actually had something related to that as well, because I think that sinusitis is a very common one. So yeah, more about the study on the only 2% sinusitis is bacterial.
Yeah, the excellent webinar recently from the University of Washington in Seattle addressing this very specific point. And they do have a reference for that percentage that I'll see if I can't track back, but we'll track that down, see if we can get that from University of Washington, Seattle.
Great. Yeah, and we can add maybe a resources slide to the end of this presentation when we go ahead and upload it. Stephen Noble says, with most URIs viral, do you utilize a WBC, a white blood cell to, or a whole blood cell to help differentiate, or do you see elevated WCs with viral URIs as well?
Yeah, I think COVID was a good example of that. Sometimes, we always said in the past that if it's elevated white count, it must be bacterial. I think it sometimes depends on the severity of the viral infection. And I don't discourage checking a white count if that helps make a decision on bacterial use or antibiotic use, or more importantly, antibiotic opportunity for avoidance. Something that has been shown in people with COPD with a flare is by checking a CRP. If the CRP is normal, then they do not benefit from antibiotics to treat flare of the COPD or the chronic bronchitis. So I think that's helpful, and a white count would be potentially helpful there as well. I don't routinely get CBCs for viral infections that are pretty obviously viral. But I think if it helps you distinguish in a particular case, then I think they are worthwhile, but not necessarily as directive as we would hope.
Dr. Tarkashvili states on the slide that describes the percentages of viruses, they add up to about 40%. Does that mean that 60% of upper respiratory tract infections are caused by other viruses?
It's a great question. That's why the estimation for community-acquired pneumonia ranges from 30 to 80% viral, because there's so many other likely viruses or mycoplasma-like bacteria or viral-like pathogens that we've yet to identify. And so I think we're making strides with the molecular diagnostics. I mean, it wasn't that long ago that we didn't know human metapneumovirus existed, for instance. And certainly COVID is an example of something we had not seen before. So I think that's a great question, and I would think that's the case.
And then have other systems in other states implemented the sort of antibiotic stewardship program that you described, and have they seen similar results, i.e. a decrease in overall antibiotic resistance?
Yeah, we worked with one state in the East. The entire state has 3 major health systems, and it's probably one of the first times they're very competitive, much like our health systems are in South Dakota. And starting in 2015. And at the time, one of the broad spectrums was the #1 antibiotic used in the state. Now, over time, that's decreased to not even in the top 5 anymore, dramatic decrease. Their C. difficile rate statewide went from higher than the national average, which was around 9 per 10,000 patient days, to now about 2.5 per statewide per 10,000 patient days, which is much lower than almost every other state. And so the hospitals that we've replicated our initial Rapid City model in, you can predictably see about a third decrease at least of MRSA. And we've had 2 or 3 just recently that have dropped in that state from quite high down to about 40%. So yeah, it's a predictable response. I think the other good point is you don't drive ESBLs and CREs to the degree that you would if you're continuing damaging your normal protective bacteria, and therefore people become colonized. The important point here, I think, is when you make an antibiotic decision, it not only potentially affects that patient that you're seeing in front of you, but if that patient becomes colonized, then potentially their family is at increased risk of colonization. For instance, if a patient has MRSA, there's a higher risk for their family having MRSA colonization infection. So essentially, there's a component of population health or public health, if you will, by being very responsible in antibiotic use, and especially the particular antibiotics you use. We found that the older penicillins and first-generation cephalosporins that are more targeted and specific don't seem to have as much of a damaging risk. And so I think if you have to use an antibiotic, trying to get as specific as possible for being aggressive at pinning down what you're dealing with and treating only for that, and trying to protect the rest of the microbiome. Excellent questions.
You're getting a lot of excellent presentations, Dr. Keegan, in the chat, so thank you.
Thank you.
I don't think we have any other questions, so I will just give it another moment if anybody wants to type something in the chat or in the Q&A. Otherwise,
I would just like to say thank you to Dr. Keegan and Randy for your presentation today, your expertise and your passion for stewardship and to make us all healthier and appropriate use of antibiotics. I would like to say if you are having trouble with your antibiotic stewardship program in your facility or you need help, just need direction, please reach out, send me an email, and I will hook you up with Dr. Keegan and Randy, and we can get you started on the right track. And we look forward to more presentations. So take a minute, fill out that survey so we know what you want to hear in the future. Thanks again, and you guys all have a great day, and thanks for joining.
thank you all. And